Hi everyone, welcome to TEPI's Infection Prevention 201 module titled Epidemiology. This is just a brief overview of epidemiology concepts, terminology, and models. Before we begin this module, I would like to introduce TEPI. TEPI is the Texas Epidemic Public Health Institute, and it's a state organization that is headquartered at UT Health School of Public Health. And the primary goal is to keep Texans safe and the Texas economy strong by preparing for the next infectious disease outbreak. If you're interested in learning more about TEPI, we have QR codes at the end of this module that can guide you to different resources you might need. My name is Oluwatoyin Akanji, and I'm a part of the Small Rural Healthcare Systems program here at TEPI. I graduated from Rural University with dual degrees in biology and health sciences, and I also have years of experience providing infection prevention and control education to the community. So today, the learning objectives of this module will be to describe and explain an introduction to epidemiology, to describe and explain epidemiology models, and lastly, to describe and explain sensitivity and specificity. This is just a brief overview, as I mentioned, and some of the epidemiology principles you'll be familiar with in infection prevention and control practices. For more details, please refer back to our previous modules and resources. So what is epidemiology? Epidemiology is the study of the distribution and determinants of disease and other conditions that affect human populations. That being said, it is also the application of this study to the control of health problems. Epidemiology involves studying various factors that can have either a positive or negative influence on human health, including both infectious and chronic diseases. This is a population-based science where factors are analyzed for a specific group and not at the individual level. And although epidemiology studies groups of people rather than individual patients, its principles are widely used in all areas of healthcare. Here are some basic terminology that you should be familiar with. The first is risk. Risk is the probability or likelihood of an event occurring. For example, the risk of developing a CODI or a CLABSI is just a probability of developing a CODI or a CLABSI. Risk factor is a characteristic, a behavior, or an experience that increases the probability of developing a negative health status. So for example, having a central line or urinary catheter is a risk factor for developing an HAI. Association is just a relationship between a risk factor and an outcome, while causation is the determination that a particular risk factor results in an outcome. Another terminology we're discussing is incidence. Incidence is the number of new cases of a disease in a certain time period, while prevalence is the number of already existing cases at a certain time. These are cases that have already happened at a particular time. And incidence and prevalence are often used incorrectly, so it's important to know the difference between the two. The next term we'll be discussing is endemic. This is the usual presence of a disease in a specific population or a geographic area. An epidemic is an occurrence of more cases of a disease than expected in a certain area among a certain population during a specific time period. And a pandemic is an epidemic that is spread over a global scale. Many epidemiology principles, along with infection prevention and control practices, involve the identifying, analyzing, and making recommendations for process improvement based on the person, the place, time, and the natural history of the event that is occurring. When looking at infection prevention and control situations, the first step is to identify the person. Who is it? Is it a male or a female? Is it a geriatric patient, a pediatric patient? The next step would be to identify where the situation is occurring. Is this infection occurring in a community, and are we seeing patients being admitted or from the facility? And if it is a facility, what specific unit is it occurring? Is it the ICU? Is it the surgical floor? Now, identify the timeline of the event. When is it occurring? When did it start? And the last step is to look at the natural history of the situation to gain more understanding. This can be done by reviewing patient charts, by discussing the chief complaints, and evaluating if this is a chronic or an infectious disease. By looking at these components of person, place, time, and natural history, you begin to gain a clearer picture of what is occurring. The next principle we are discussing today is the epidemiology triangle of disease. It is important to understand the interaction to implement an effective infection prevention and control program. The epidemiology triangle disease model comprises of the host, the agent, and the environment. The host is a human or another animal that can be characterized by genetic factors or demographic factors, while the environment consists of all external factors associated with the host. This can include the biological, physical, and psychological environment. The agent is the pathogen causing the disease. This can be bacteria, fungi, virus, etc. And in this interaction model, change in any component will alter the existing equilibrium. So change can either increase or decrease the frequency of disease. Another important model we'll be discussing is the chain of infection transmission. Understanding the chain of transmission and their relationship to each other is critical to determine the risk of infection and the needed intervention to interrupt the disease transmission process. This allows staff to identify vulnerable patients and to take necessary precautions to protect themselves. Each chain in sequential order must be present for an infection to occur to create the infectious disease process. And it involves 6 components. The first is the infectious agent. This is the pathogen causing the disease. So this can either be bacteria, virus, fungi, etc. The next component is reservoir. This is the place that the pathogen lives and can multiply. So it's an environment that is conducive enough for the pathogen to grow. This can be a dirty surface, soil, water. It can even be other animals. The portal of exit is how the pathogen leaves the reservoir. So this can be through open wounds, aerosols, body fluids that are produced during coughing, sneezing, or saliva. The next component is the mode of transmission. This is how the agent is passed on. This can be through direct or indirect contact with the infectious agent or by ingesting or inhalation of the agent. The portal of entry is the way the infectious agent can enter a new host. This is through broken skin, the respiratory tract, mucous membranes, and catheters and tubes. And the last component is the susceptible host. This is any person that is at risk of being infected by the infectious agent. For more information on this specific concept, please refer back to our TechFE Model 1 on the TechFE website or the YouTube channel. The third model we'll be discussing today is the wheel model of disease causation. The wheel model consists of a hub, which is the host or human, with an inner core of genetic information. The environment surrounding the host is divided into 3 parts. This is the physical, biological, and social environment. And the size of each component is related to the disease process under consideration. For example, the genetic core is large for hereditary diseases, but it will be small for viral diseases. This model does not emphasize the agent per se. Instead, it focuses on the interactions between the host and the environment, and the agent and the environment. And when doing infection prevention and control workups, developing policies and implementing procedures, this relationship will help to guide you in the process. Another model we'll be discussing is the web of causation model. This model aims to capture the more complex interaction between the biological, environmental, and social factors that can contribute to the disease. It emphasizes the contribution of social and political factors of human life and how these are interrelated to other contributing factors. Here is just an example of the web of causation, and in epidemiology, this is often referred to as the DAG model, which is the directed acyclic graph model. So, when examining DAG models and relationships, a certain number of associations will simply occur by chance. These are known as artifactual associations. There will be an increasing number of associations as more factors or variables are studied, and this is known as random error. Artifactual associations may also be caused by errors in study design or analysis, and this leads to an introduction of a systemic error or systemic bias. The next type of association is indirect or non-causal association, and this can result from the mixing of events of effects between the exposure to the disease and a third variable, which is known as the confounding variable. And the confounding variable can either be associated with the exposure and it will independently affect the outcome of interest. The last type of association is a causal association. Causal associations exist when evidence indicates that one factor is clearly shown to increase the probability of the occurrence of a disease. In a causal relationship, the reduction of a factor decreases the frequency of the disease being studied. A causal association should not be confused with causality, which requires a number of conditions to be met, one of which is the presence of causal associations. Also, when analyzing relationships between the agent, the host, and the environment, you want to determine if the relationship is true. Sometimes relationships can be confused or the picture can be foggy because of the presence of confounding factors. So what is confounding? Confounding is a mixing of effects between an exposure, the outcome, and a third variable. We do not want this effect. Therefore, researchers want to put mechanisms in place to control for confounding effects. An example of this would be an individual being admitted to a facility who already had a central line placed on admission. And within 72 hours of admission, the blood culture comes back positive for E. coli. The line could have been affected before admission because we do not know how it was maintained prior to admission. Or the positive blood culture might have developed from how the central line was placed after admission. So this is a confounding relationship. To control for this, blood cultures should be obtained on admission when individuals are admitted with a central line to check for already existing infections or illnesses. Next, sometimes a relationship can be modified either positively or negatively by another factor. This is known as effect modification or effect measure modification. This is the strength of association between exposure and diseases that has an effect on a third variable. We want this effect. This is a desired effect. Therefore, we want to report and examine this relationship. An example of effect measure modification would be the risk of developing infection increases when an individual is immunocompromised. With this knowledge, infection prevention in single rooms or isolation cautions can be implemented to try to prevent them from developing an infection. The next principles we'll be discussing is the Hill's criteria of causation. These are 9 principles that can help you to determine causation. The first is the strength of association. This means that the incidence of disease should be higher in those who are exposed to the factor under consideration than in those who are not exposed to the factor. That is, the stronger the association between an exposure and a disease is, the more likely the exposure is to be causal. The next criteria we're discussing is consistency. The association should be observed in numerous studies done by different researchers using different methods. The next is specificity. It means that a strong and specific association between one exposure and one disease means that it's likely to be a causal relationship. This also refers to the extent to which the occurrence of one factor can be used to predict the occurrence of another factor. Temporality. Exposure to the hypothesized causal factor must occur before the onset of disease. Biological gradient refers to a dose-response relationship between increased exposure to a factor and increased likelihood of disease. So that means greater exposure should generally lead to greater effect. Biological plausible. For a causation to be deemed biologically plausible, there should be some logical or scientific reason behind this causation. And because biological knowledge is always expanding, the lack of biological plausibility does not necessarily disprove a theoretical association. The next criteria is coherence. The evidence of association must be consistent with other facts known about the natural history of the disease. Experimental. There should be an experimental evidence that adds considerable weight to the evidence supporting causal association. And this can either be clinical trials or animal studies. The last criteria is analogy. If there is a known causal association within a similar exposure and an outcome, the association that is under study is more likely to be a causal association. And it's important to know that these 9 principles all have to be present for causation to be established between an exposure and an outcome. So let us walk through an example using C. diff. The strength of association means that the infection was developed from an exposure to the organism. So it's more likely that the patient was exposed to C. diff before they got C. diff. Consistency. C. diff has been studied with detailed research conducted on signs, symptoms of C. diff, which examples are watery or bloody diarrhea. Specificity. Signs and symptoms would have been observed that are directly related to C. diff infections. The next criteria is temporality. Exposure must have occurred prior to developing signs and symptoms and with the appropriate incubation time of the organism. So let's say the patient has been admitted for 5 days. So exposure must have occurred before the incubation time, which is 2 or 3 days, before they started showing signs and symptoms of C. diff. Biological gradient. A larger bacterial load will lead to an increased likelihood of infection. C. diff is biologically plausible to cause signs and symptoms of infection based on toxin production or organism. The next criteria is coherence. Disease from C. diff is coherent with causing gastroenteritis. Also, for the experimental criteria, previous studies provide support of a causal relationship between C. diff exposure and disease development. And the last criteria, analogy. Experiments show that watery bloody diarrhea are related to C. diff. The next principle we're discussing is sensitivity and specificity. Sensitivity is the probability that a test correctly identifies positive individuals who have the disease. Sensitivity is a measure of validity, which can show how valid a laboratory or diagnostic test is. This is calculated by taking the number of individuals with the disease who test positive divided by the number of individuals with the disease multiplied by 100. So the higher the number, the more sensitive the test is. And this is an important concept to understand because it plays a primary role in detecting the correct positive rate of a disease in the community. During outbreak investigation and laboratory product evaluation, you want to ask what the sensitivity is. The higher the sensitivity, the stronger the test can identify a positive test. So here's an example of a 2x2 table of how sensitivity can be calculated. The disease rate is at the top, which is the vertical aspect, and the test rate is on the side, which is the horizontal. So box A is the number of individuals who have the disease and test positive. This is known as true positives. Box B is the number of individuals who don't have the disease but test false. This is false positive. Box C is the number of individuals who have the disease but test negative, which is also known as false negative. And lastly, box D is the number of individuals who don't have the disease and also tested negative, which are the true negatives. So this is calculated, sensitivity is calculated by having all the true positive divided by the true positive plus the false negative. Specificity is the probability that the test correctly classifies an individual probability as negative. It is also a measure of validity along with sensitivity, and this can show how valid a laboratory diagnostic test is. It's calculated by taking the number of individuals without the disease and tested negative and dividing it by the number of individuals without the disease multiplied by 100. This is an important concept to understand too, and it plays the primary role in detecting the corrective negative rate of a disease in a community. During outbreak investigations and laboratory product evaluations, you also want to ask what the specificity is. The higher the number, the more accurate the test in correctly identifying the individuals without the disease. This is also a 2x2 table showing you how specificity can be calculated. It's calculated by having all the true negatives divided by the true negatives plus the false positives. So we're looking at the levels of prevention in facility. Prevention is a key component of infection prevention and control programs. Deciding what level of prevention that is needed for a particular situation is crucial. The levels of prevention we'll be discussing at the primary, the secondary, and the tertiary levels. The primary prevention occurs before the pathological onset of the disease occurs, and it is aimed at reducing the incidence of a disease. An example of a primary prevention will be vaccinations, for infectious disease obtained just as like flu, RSV, or MMR. Another example is creating and implementing policies to maintain clean and sterile supplies of water, food, and medication compounding. Secondary prevention is implemented to reduce disease. So this is mostly seen in identifying asymptomatic individuals. An example of this is testing individuals for infectious diseases when an individual has already been exposed to a pathogen but doesn't show signs of infection yet. The last level of prevention is the tertiary level of prevention. This is done to slow or to block the progression of disease. So this is implemented after a clinical diagnosis has been made. An example of this would be good antibiotic stewardship by a culture from an infectious site that is obtained, sent to the lab, and a make report reviewed to ensure that the other antibiotic is effective in treating the infection from the cell. To wrap up this model, epidemiology is a very broad field that involves looking at multiple factors that can affect the distribution and determinants of disease and other conditions in human population. This uses multiple epidemiology terms that we've discussed today, the concepts and models that ensure safety for both the staff and patients in the facility. So immediately after this lecture, a post-survey evaluation email will be sent out to those who attended today's model. We would appreciate it if everyone can complete and provide the team with feedback. And you can scan the QR code that is on here, and you'll be able to access the survey related to what you've heard today. And during the survey, you can enter your email for a chance to win free Techie swag. We invite you to connect with us. This is our email. You can email us at ipc@tefi.texas.gov, or you can ask general inquiries at info@tefi.texas.gov. Two of our QR codes are here. The first is to register for upcoming webinar series, and the second is just our website. It's our references used today. And now it's your turn for a knowledge check. If you can kindly scan the QR code to lead you to a couple of questions that you can use to test your knowledge on what you've heard today. Okay. I believe everyone has it pulled up already. Okay, so the first question is, epidemiology is the study of what? Is it the distribution and determinants of disease and other conditions in human populations? Or is it the study of the disease and interactions that occur in people? Or is it option C, the associations between the agent, host, and environment? Or is it the last option? Is epidemiology the study of a relationship between the exposure and outcome? Which one do you think is the right answer? Next question. What are the main epidemiology factors that infection prevention and control looks at? Is it person, place, time? Or is it person, place, time, or natural history? Is it person, place, natural history? Or is it the last option, person, time, and natural history? Question 3. What are the 3 components in the epidemiology triangle of disease? We quickly touched on this. Is it the host, environment, and outcome? Is it the person, exposure, and environment? Is it the host, agent, and environment? Or is it the last option, host, agent, and outcome? Next question. What are the components of chain of transmission? We discussed 6 components today. So which one is it? What option is it? You're all done. We'll move on to the next question. In the real model of disease causation, which 3 components are in the outer ring? So do we have the host environment, the social environment, and physical environment? Or do we have the biological, the host, and the physical environment? Do we have the biological, social, and physical, or do we have the biological, social, and the agent environment? So which of the three are in the outer ring of the model? Next question. How many types of association are there? So we discussed types of association today. So are there 2, 3, 4, or 5 types of association? Next question. What is more wanted, confounding or effect modification, and why? Why is it more wanted? Do we want confounding or do we want effect modification? I'll give you a couple more seconds to think about the options. Which one is the right answer? Next question. How many components are in the Hughes criteria of causation? Are there 6 components, or 7, 8, or 9? And as I mentioned during the lecture, all the components have to be present in when determining causation. So what components, how many of them have to be present? All of them, or how many components do we have? Next question. What is the sensitivity formula? Is it true positives over true positives plus false negative, or is it true positive over true positives plus false positive? Or is it true negatives over true negatives plus false positives, or is it the last option, true negatives over true negatives plus false negatives? So what is the sensitivity formula that we mentioned? Question 10. Set up a 2 by 2 table and calculate the sensitivity. So 100 individuals were tested for influenza. 20 had symptoms and the positive test. 5 had symptoms but tested negative. 5 had no symptoms but tested positive, and the remaining 70 individuals had no symptoms and tested negative. To calculate the sensitivity from here and set up the 2 by 2 table. Also give it some time to set up the table and to calculate the sensitivity. We'll also be showing the answers at the end so you can check to see how well you did. Okay, so if you got all these answers and for the last answer, if you got 80, so you were right. And yes, I think I got a 90. Yeah, you did well. That's great. Yeah, thank you everyone for today. If you have any questions, it's now open for any questions. Yes, there'll be a record. You'll have access. Yes, you will have access to the question to the slides today. We're providing it on the website, so if you can QR code and check in a couple of days, you should be able to access the presentation page. Any other questions? Yes, we have it pulled up right now for the QR code for feedback. Also, our next model is on March 7 and it's going to be titled Occupational Epidemiology and Prevention. It's also going to be the same time, 2 to 3. So, like, you can register and attend. Okay, if no other, so one person has a question. Of all of Hale's 9 points, which one do you feel is the most important? I feel like everything is important equally because everything has to be present for you to establish causation between the risk factor and an outcome. So everything is important equally. So is there anyone you believe is more important than the others? You can also feel free to unmute and respond. Okay, if you don't have any other questions, thank you very much for attending today's lecture and have a great one.